Assalamu alaikum, everyone. Bismillah ar-Rahman ar-Rahim. So we'll start on time because I was told that there'll be a lecture at 10 o'clock. But inshallah, we'll finish much earlier so that you can rest before the actual lecture. It's just a practically easy because we are just going through the pictures and the slides of the pictures which we discussed yesterday. So this is the practical of atherosclerosis, myocardial infarction, and thrombosis. The ILOs, in the ILOs, we will see the gross and microscopy of atherosclerosis, of myocardial infarction, aortic aneurysm, pulmonary embolism, and then we'll see the infarctions, different infarctions, two types of infarctions. Here we will discuss and see the pictures. We have not touched this in the theories, so we'll slightly do more on it. And this is the file which was given to me by the coordinator, and this was done last year also. I've made some minor changes, so it is not the actual thing which is to be given. I will give you more from my lectures to the dentistry students at the end if we get some time, because many of the necrosis and infarctions are missing. So we can see the pictures of that from that file of dentistry students, inshallah. So we go to these are the images which we are going to see: atherosclerosis, myocardial infarction, aortic aneurysm, pulmonary embolism, and infarctions. Four types of pictures we will see in infarctions. Some of the good things which were present in this file, so I've kept it just for a revision. The definition is slightly different. Everyone can define some topic or a subject slightly differently. So this file said that this is atherosclerosis is a slowly progressive disease of arteries, which is characterized by formation of fibrofatty plaques called atheromas. That is what we know. The only new thing which is here is that it is a Greek word. Atheroma is a Greek word which means porridge. So they have kept this picture of porridge in this slide. So atheroma means porridge. So that lesion looks like porridge with yellow areas and whitish areas, inflammation and fat. That is why it has been called porridge by the Greek people in the history. This is also a good picture. I thought I will show you again just for a revision. It is showing the evolution, how the atherosclerosis starts and what are the different stages, which we have seen them yesterday, but in slightly different style. So in the first one, you can see the normal healthy artery, the normal flow, and the normal lumen. And then in the first stage, there's slightly small plaque or just a fatty streak or yellow streak here, which is in the longitudinal section and the cross section, little bit. Then it becomes a middle stage, slightly progressive phase, and you can see proper plaque, the fibrofatty plaque. We have the cap here, and it is now increasing in size, and the lumen is now decreasing. It is the narrow lumen in this stage. We call it progressive phase of fibrofatty plaques. And the final stage is the complicated phase and the late stage of atherosclerosis, when the plaque is very large and covering more than 70% of the lumen. And this is the stage of complications, and this is the stage of clinical features. The patient will start having angina, that is pain when he's walking or doing some exertion. He may be okay when he's resting or sleeping, but when he walks and do some exertion, he will have symptoms and chest pains. So this is the stage of complications. And the plaque will also may develop some ulceration, and from that ulceration, hemorrhage and thrombosis can occur, and myocardial infarction will occur after the thrombosis. That's complete blockage after the thrombosis. At this stage, there's no blockage, complete blockage. Still there is some blood flow in the last stage. So this is the first picture, histology, microscopy of normal coronary artery. You can see very nice large lumen, and this pink color is the media you can see because it's a low power picture. So these are the smooth muscle fibers in the media, the middle layer. The inner layer is the intima. This is the media, and outside is the adventitia, which you see the blood, the fatty tissue, and the small capillaries. These are the small capillaries, red in color, in the adventitia. So it's a normal coronary artery. And on this side, you can see that there is atherosclerosis. You can see the atherosclerotic plaques here. Lumen has become small in size. And here also you can see the whitish areas of fatty deposition, which are more clear in the high power. We will see now. So when there's severe narrowing, it will lead to ischemia. What is ischemia? It is the decrease in the blood supply. When there's decrease in the blood supply, there's decrease in the oxygenation of the tissues, and the patient can have angina, which is the minimal first stage of the clinical symptoms, and infarction is the last stage when the muscles of the heart will be necrotic and dead. This is the adventitia. You can see the fibrofatty tissue around it, and these are the nerves. This is the nerve, and these are the capillaries. These are the capillaries, these are the nerves, solid pale colored nerves. This is more severe form of atherosclerosis in the coronary artery. This is the peripheral artery, because now you can see the muscle also. This is at the periphery, away from the origin. This is the distal part, peripheral part of the coronary artery. And you can see the narrowing is more than 70%, 80%. So it is a significant narrowing or severe coronary atherosclerosis, depending on the person how they can call it. So all these, one can say it is significant narrowing. Okay, we agree. Someone can say it's severe coronary atherosclerosis. We agree. So all these are the different names given to it. These changes are usually seen in patients of diabetes or in the genetic disorder called familial hypercholesterolemia. So this is the severe stage. The severe coronary atherosclerosis can be seen in diabetes mellitus and familial hypercholesterolemia. Two examples have been given in this slide. This is the gross picture of atherosclerosis. These are three aortas. These are the gross pictures of aortas. The lower one is showing mild changes. This you can see only this area showing some yellowish areas. Otherwise, the remaining, these are openings, opened up aortas. These are the opening of the blood vessels, intercostal arteries. This is the bifurcation of aorta going into the common. What are the arteries after bifurcation? Anyone knows what happens? Aorta bifurcates into
iliac artery.
Common iliac artery. Yes, mashallah. So common iliac arteries, which then again divide into internal and external. So this is the bifurcation of aorta, and very little changes. This is the mild changes, only some white areas, yellow areas. Now this is the moderate changes. In the middle one, you see the moderate changes. You can see more yellow areas, but no ulceration, no necrosis. Here you can see all the severe changes in this aorta. You can see this is ulcerated areas. Some of the hemorrhages also, these dark areas are the hemorrhage and irregularities. So this is the severe form of atherosclerosis in the aorta, mild, moderate, and severe. This is the microscopy of the atherosclerosis of the aorta. On this side is the adventitia. This is the normal outside of the aorta. This is the media. You can see the dark pink color and smooth muscle fibers of the aorta. And this is the atheroma or atherosclerosis, this part. In this, you can identify these needle-like areas, the whitish areas. These are cholesterol needles or cholesterol clefts. These white things are the cholesterol clefts. They are numerous here. And if you go towards the lumen of the aorta, it is ulcerated. The surface The inside surface, you don't see any intima. The surface is ulcerated and hemorrhagic. This is RBCs. All these are the red color RBCs, and the surface is irregular. So this is a severe form of atherosclerosis of the aorta, and this is how we see under the microscope after staining with. Anyone knows the name of the stain? Hematoxylin and eosin stain. They write H and E. This is the routine stain we do, hematoxylin and eosin. The normal stain which we do, but there are some special stains also. Most of the slides you see in histology and histopathology in the pathology are like this, in these colors. This is the heart, the normal heart, gross picture. You can see the surface is very shining and glistening. The outer surface is called epicardium. Then in the middle we have the muscles or the myocardium, and inside we have the endocardium, right? So this is the outer surface, is the epicardial surface, which is smooth and glistening, is shining. And you can see little bit of fat, not much. This much fat is allowed. Then on the anterior surface, this is the large artery, coronary artery called left anterior descending coronary artery. This is the normal artery. This is the largest artery supplying the heart. So whenever there's thrombosis or blockage of this artery, usually the patient dies. It's very sudden death because of the blockage of the artery. Please mute, someone is talking, listening to TV or something. What is it? Thank you. So when this artery is blocked, the patient usually dies. So that is why some people, they call it widowmaker. Widow is the lady whose husband is dead. So that is why they call this artery as widowmaker artery. So this is the largest artery supplying the heart, left anterior descending coronary artery, going from the top to the apex of the heart. This is the normal heart. And this is also a normal heart which has been sliced cross section. You can see that this is the thickness of the left ventricle, and this is the right ventricle wall, and the right ventricle is collapsed. It is hidden, and but this the left ventricular cavity, left ventricle is open. So this is the normal slice of the heart to show the normal surface. It is pinkish in color. There is no irregularity in it, though discoloration. But now when we see these ones, after the microscopy, we'll see the changes in the myocardial infarction. So this is the normal microscopy. All these are the longitudinal fibers of the heart. These are the rounded central nuclei. And you don't see the separation. We call it syncytium. Syncytium means they are just combined. You don't see one cell separate from the other. So they have a syncytial arrangement of the fibers. But there are some other features which you can see, which is not so clear. You can see this one. This is the horizontal line. These are called intercalated discs. Not so clear in the H&E, but you can see the diagram. The heart muscles, the myocardial muscles have intercalated discs which separate the cells, which are not so clear. That is why muscles look like syncytium. They look like one big area, no separation. You can identify the fibers, but not separately. And these are the nuclei, central nuclei. In the skeletal muscle, the nuclei are peripheral. In the myocardial muscle, they are central. That is another difference. In the skeletal muscle, the nuclei are peripheral. In the myocardial muscle, they are in the center. So this is the gross specimen of the heart, which has been sliced. This patient died because of the recent myocardial infarction. This is the left ventricle and the right ventricle. This is the right ventricle here. And you can see this yellowish area. This is the infarction. This coming from the anterior surface, going into the interventricular septum. The two ventricles are separated by the wall, the septum called interventricular septum. So this is a large myocardial infarction. And it is transmural also. It is extending from the full thickness of the wall. Usually if you say and subendocardial, just they are here, only very small areas, but this is transmural. Transmural means it is going through the full thickness of the ventricular wall. So this is a recent myocardial infarction. Otherwise, there are no fibrosis. There's some redness also because whenever there's infarction, there's inflammation also. So these features are present in this one. Under the microscope, these are two pictures. One is immediately after infarction. You see there's hemorrhage. All these RBCs have come out, and this is extensive hemorrhage in this picture. And the myocardial fibers are still visible, but you can identify the nuclei also. They are starting, some nuclei are now disappearing. The feature of infarction is that there are no nuclei. Here you don't see any nuclei, only this blue color is of the neutrophils. These are the neutrophils, inflammatory cells, but actual nuclei of the myocardium have disappeared. So under the microscope, what is the most important feature of infarction, recent infarction, is absence of nuclei. You don't see any myocardial nuclei in this one. Here only occasionally you can see. So they are disappearing. Immediately after infarction, you see hemorrhage, but after 3 to 4 days, you see inflammation. You see neutrophils, acute inflammatory cells, they are coming and trying to remove these dead muscle fibers. You can identify that they are elongated fibers, but you cannot identify the nuclei. That means they are necrotic, they are infarcted. What to do? This is a gross specimen of old myocardial infarction. How can we say it's old? Because if you compare this wall here, the wall, thickness of the wall near the top is this much, and here you see it's almost finished. Very thin wall near the apex. The free wall, there's very little thin wall, and this is fibrous. Here you can see the muscles, but here don't see any muscles. It's all, here also you can see the muscle, but here it has disappeared near the apex. It's just thin fibrous wall. Fibrosis occurs, it takes weeks to come. So this is now an old myocardial infarct. And because of there's no muscle here, only fibrous tissue. So when the heart contracts, this bulge out, it becomes an aneurysm. We saw the pictures of the aneurysm of aorta yesterday. So this is the actual picture of the aneurysm of the heart. There's ballooning or bulging of this area when the heart contracts. So this is old infarct of the heart and leading to myocardial aneurysm, because there's only collagen, there's no muscle. The muscle is up to here only. There's no muscle here. So it's an old infarct. If you look at the section under the microscope of an old infarct, you see fibrosis. This pink thing is the fibrosis, light pink is the fibrous tissue. If you do special stain, collagen stain called trichrome stain, it will appear blue in color. But here in the routine stain, it is light pink, and dark pink are the muscle fibers, myocardial fibers, which are alive. They are the surviving fibers. They are not dead. Only the fibers in this area were dead, and they have been removed and replaced by the fibrous tissue. The muscle fibers which are alive, they are now large in size. We call them hypertrophic. They are hypertrophic because now they have to work extra, because their friends have died here, so they have to do extra work, so they become hypertrophic. Just like an athlete, they do exercise and the muscles they develop. Similarly, myocardial fibers, they have to work hard, so they are hypertrophic. You can see these hypertrophic changes here. But this is, that area is replaced by the fibrous tissue or scar tissue. This picture is showing the changes according to the time. There were many other graphs, written graphs, which I've removed because they were more confusing, but this is a good picture to show you that if the infarct is 1 day old, if the infarct is only 1 day old, you can only see some irregularity or waviness of the fiber. This is the normal part, and this is the waviness of the part. You see very little nuclei. The nuclei are disappearing in this part. The inflammatory cells have not come in 1 day. They take 2 to 3 days to come. And this is called coagulative necrosis. We see the definition of coagulative necrosis after some time now. So coagulation necrosis occurs in the heart after infarction. Infarction is actually coagulative necrosis. So after 2 to 3 days, you see a lot of inflammatory cells between the fibers. The fibers, they have no nuclei. There's no nuclei in the fibers. They're all dead. So the inflammatory cells, the neutrophils, they come and they try to eat up and remove these fibers. In few days, neutrophils come. After 4 or 5 days or after a week, larger nuclear cells come. They are called macrophages. In the beginning, neutrophils come. They are also called microphages because they are small and they are also eating the dead tissue. Microphages. The macrophage are the larger cells. They are the large eaters. They will come after 4 or 5 days. So they will also eat up these muscles, and then fibrous tissue will start coming. The fibrous tissue, the scarring, I think I took the lecture on healing, etc. In the beginning, the fibrous tissue is young. We call it granulation tissue. When the fibrous tissue or the scar tissue starts coming, healing starts. In the beginning, it is young. We call it granulation tissue. It contains blood vessels, capillaries, and only little bit collagen. These are special stains. These two are special stains called trichrome stain. You can see that the collagen is blue in color here now. Here, very little blue color here, but after 3 weeks, you see a lot of blue color. This collagen is more and more blue color. Now it is scar. We call it a scar formation after 2-3 weeks. Now a complete scar has come and only with very little pink tissue is left. These are the pink fibers of the muscle. Most is replaced by the dead cells are replaced by the collagen, which is now, you can see, blue in color, and we call it scar tissue. So the microscopic feature on day 1, there's only some waviness, irregularity of the fibers. Nuclei you can still see, but no inflammation after 1 day. After 2-3 days, you see inflammatory cells coming. In the beginning, neutrophils, they come, and after 4 or 5 days, macrophages also come. The monocytes, they come and they start eating the tissue. And after 1 to 2-3 weeks, granulation tissue is formed. What is granulation tissue? It is a young scar tissue which contains the capillaries and very little collagen. After 3-4 weeks, more and more collagen is deposited and the granulation tissue is converted into a scar tissue, a fibrous tissue, which you can very clearly see in this special stain, a lot of blue color because of the collagen or because of the scar. Now coming to the second topic of aneurysm. This is one of the complications of atherosclerosis. Whenever there's atherosclerosis, there is weakness of the media, there's degeneration of the wall, and where there's weakness of the wall and the smooth muscles, there is scarring, and then the bulging occurs. The wall becomes weak, and you can see this is the aorta, and these are the 2 kidneys. And near the bifurcation, you see this balloon in the aorta. This is called aneurysm. Because of the atherosclerosis, there's weakness of the wall, and because of the pressure of the aorta, it balloons out and becomes a ball-like thing. These can rupture and cause sudden death. And if you feel them in a patient, you can feel them from the abdominal examination. You can feel they are pulsing. They are pulsatile masses. They are just like heartbeats when you touch them from the abdominal examination. They are large in size, and if they are becoming 6 to 7 centimeters, they can rupture. They can burst and cause sudden death of the patient. This is an aneurysm of the abdominal aorta. near the bifurcation. This is one of the complications of atherosclerosis. When you open this aneurysm, you see it is mural. Mural means it is in the wall. The lumen is still open because large area. So the atherosclerosis has the mural thrombus. The thrombus is formed because the blood is not flowing in this area. So slowly and slowly clotting occurs and thrombus formation occurs in the wall, near the wall. The center will have the blood flow. The blood flow will continue. Blood will come from here and go to the bifurcation towards the legs and the pelvis. In the periphery of the aneurysm, thrombus forms, and because it is near the wall, we call it mural thrombus. And because some flow of blood is there, these thrombi will have a layered appearance. Some RBCs and again platelets, some fibrin. So they also always have this layering appearance. You can see we call them lines of Zahn. We'll come to that in a minute. Similarly, we see this is embolism now. That thrombus, suppose, was present in the aorta. Some of that part of that thrombus get detached, and it comes through the inferior vein. That was not. It will not come from the aorta. The thrombi from the veins in the legs, they get detached to become embolism. The thrombus, if there's thrombosis in the veins of the legs, they will get detached and they'll be embolizing. We call it embolism. They'll go through the inferior vena cava, to the right side of the heart, and they'll reach the pulmonary artery. And when they reach the pulmonary artery, they can block the pulmonary artery. If they are large in size, they can block the main artery and cause sudden death. If they are small in size, they can cause infarction. So this is an embolus which came from the vein in the legs and has reached. So you can here also see that some part is red, some is whitish, and here is all you can see the layering appearance. Different layers or different colors in the thrombus, in the embolism. It was thrombus, it got detached. You remember the cancer, where you have studied cancer, the primary is from the primary you get the secondaries or the metastasis. Similarly, the primary is the thrombus. From there, the detachment, we call it embolus, which circulate in the circulation to reach the lung. So this is an embolus in the pulmonary artery. It has a layered appearance, which is typical of a thrombus, where they are formed in the large veins. When you make a slide of these thrombus, again, this is the lung tissue. Here, see the lung tissue. And this is the pulmonary artery. And this is the thrombus here. You can see the layering. This is the RBCs. And then the pink area is the fibrin and platelets. This forms a layering appearance. This is more clear in the high power. This is the high power picture. You can see the RBCs and the pink, light pink and the dark red, pink. These are called lines of Zahn, Z-A-H-N, lines of Zahn, because of the flow. Because if you look at the clot, if you put a blood in the test tube, it will clot. All the RBCs will be separate and platelets and things will be separate. You won't find layering in the clot. You'll find the layering only in the thrombus because the blood is flowing also. That is why you get this layering. This is a big embolus. We have seen the similar pictures of saddle embolus when they come and get lodged in the bifurcation of the pulmonary artery. So this is a big saddle embolus in the pulmonary trunks and the branches, main branches of the pulmonary arteries. And you can see some irregularities, some shininess. And this is, when you take it out, it is still intact. And you can see this is a saddle embolus. It looks like the vein from which it is coming. That was about the different pictures which I've seen. Now we come to the necrosis. What is necrosis? The definition of necrosis is the localized death of tissues in the living body. You cut someone's hand and keep it on the table, it will die because of it will not get oxygen and blood, but you will not call it necrosis if you put it outside. Necrosis is when the tissues died inside a living body. This is necrosis. There are many types. You can classify them in many ways, but this is the usual one they classify: coagulative, liquefactive, caseation, fat. And yesterday some of the students, they asked about the gangrenous necrosis also. I'll try to show you that pictures if we get time. So what happens in coagulative necrosis? It occurs in ischemia when you don't get the blood supply, the tissue does not get the blood supply and oxygen. So that tissue coagulates, it remains solid. If you see under the microscope, you can identify the tissue. You can see that nuclei are absent, but you can still see that, oh, it was myocardium, it was kidney, it was like that. So it is coagulated like the clotting of the yogurt or the curd. So it gets coagulated like blood clot, but you can still identify the structures. They are dead, but you can identify in the microscope the structure. But of course, when you look at the liquefactive, cannot identify what it was originally. This happens in the abscess and in the brain. Why in the brain? Because the brain has a lot of fat. The brain has a lot of lipid tissue, a lot of fat. So whenever there's necrosis in the brain, it gets liquefied. It becomes oil and it becomes liquefied. That is, liquefactive necrosis occurs in an abscess. Abscess means there's a localized collection of pus due to infection, bacterial infection, and that causes liquefaction because of neutrophils and etc. Pus formation. That is also liquefactive necrosis. And the brain, because there's a lot of fat in the brain. Caseation necrosis is a special type that occurs in the tuberculosis, and it looks like a cheese, and caseation means cheese-like, and it also occurs in hypersensitivity reactions, etc. But you just remember caseation necrosis with the tuberculosis. Again, fat necrosis. You may say that a fat necrosis may look like a liquefactive necrosis, but not. Fat necrosis under the microscope has a very special picture. It has big white areas because fat does not take the stain. I'll try to show you that slide, inshallah. So the main cause of fat necrosis is trauma. Whenever you damage the fat, it will get necrosed and get a special picture. And fat necrosis occurs also when there's pancreatitis. Pancreatitis, you know, the main enzymes of fat digestion, they are coming from the pancreas, the lipase from the pancreas. So when there's an inflammation or infection of the pancreas, those enzymes will cause fat necrosis around the fat around the pancreas in the abdomen. So fat necrosis can occur because of the enzymes released from the pancreas or by trauma. These are the two important causes of fat necrosis. So we'll see 4 pictures of necrosis. Now we come to classify what is pale necrosis, what is red necrosis. We call it pale because whenever there's stoppage of circulation, complete stoppage of circulation in an organ which has only one blood supply. Spleen has only one blood supply. So when artery is coming here, there's a blockage here at the apex. So this part which was supplied by that artery will become necrosed. There will be no blood in this area. So it will appear pale in color because of the absence of necrosis, absence of blood. That is why it looks like pale or yellowish in color. That's why it looks triangular, because the artery is here and then this area gets no blood supply. It is also called anemic infarct. Anemia, you know, when there's less blood in the circulation, the person is anemic. So they are also called anemic infarct, pale infarct, anemic infarct, and they are usually triangular in shape or wedge shape. They are also called wedge shaped or triangular in shape in gross appearances because they have only one blood supply. Blockage is here and this area becomes dead. So this occurs in the spleen, in the solid organs which have only one blood supply. Similarly, in the kidney also. Kidney is a solid organ, and if the blockage here and this part which was supplied by this artery gets necrosed, it gets no blood in this area, so it appears pale in color, yellow in color, and anemic in color, and this is wedge shape. And at the edge, you can see some inflammation, because whenever there's necrosis, inflammatory cells will come and try to digest this part. So infarction in the cortex of the kidney is also wedge shaped and salt pale. But we look at some organs which have double blood supply, like intestines. In the intestine, there's double blood supply. They are called collateral circulation, double circulation, or anastomosing circulation. So when that part gets died, blood will come in that dead part from other supply. So they will look red in color. They will look hemorrhagic. That is why I call hemorrhagic infarction or red infarction. This also occurs in the spongy organs, which is sponge-like lung is sponge-like. So in that also you can see red infarct. So this is the dark color of the hemorrhagic infarct or red infarct of the intestine. Another reason it is not even red, it is more black in color. Now I will answer the question of my student who asked about gangrene. So here, you know the GIT, the large bowel, they also have bacteria inside. They have an anaerobic bacteria. Their bacteria, they will grow in this dead tissue and they'll start eating. These bacteria are saprophytic bacteria. They live on the dead tissue. And the black color is because of the growth of those bacteria. So that is why it is also gangrenous, black in color, very bad smelling, gangrenous, necrosis also. This is also called gangrenous because of black in color. The gangrene usually occur because of the action of the bacteria, special bacteria that grow, that need the dead tissue. Saprophyte bacteria, they need dead tissue. So this is also black in color. The intestine get gangrene. So the gangrene is hemorrhagic also. This is hemorrhagic also, but it becomes later on blackish in color because of the gangrene. Then infarction in the lung is also red in color. It is also hemorrhagic because it has double blood supply, the actual supply of the pulmonary artery and also some capillary supply from the intercostal blood vessels, etc. So the hemorrhage in the infarction in the lung is also red in color. So we can ask you questions: which organs have red infarction, which organs have pale infarction? You can remember. Now here also this very important thing which I mentioned previously, because lung get all the blood from the veins, from the veins to the right side of the heart and to the lungs. So all type of embolism of different sizes can reach the heart, reach the lung. We have seen that when they are large, they are saddle shaped, they are large, they will suddenly block the circulation and sudden death can occur in the lung. So there will be no infarction, only sudden death. There's no time for infarction, all patient will die. So if the emboli are large in color, if the emboli are large in size, then they will cause sudden death. If they are small in size, very small emboli coming from the small blood vessels, veins of the legs or hands or anywhere in the body, they are small in size, they will not cause much damage. But if they keep on coming from long time, they'll call fibrosis and they'll cause pulmonary hypertension because of fibrosis coming from the small emboli for long time, then they can cause pulmonary hypertension. The medium-sized emboli, those which are in medium size, they will cause these hemorrhagic type of infarction. So the small emboli, they will cause no damage, or very tiny, small infarct which become fibrosed. The patient will have no features, but after some time they will develop pulmonary hypertension. If they are very large, the patient can die suddenly because sudden blockage of the blood supply. There will be no infarction, but sudden death, as in saddle-shaped infarct, but the middle-sized infarct, when the emboli, when they reach the lung, they will cause this red-colored or hemorrhagic infarct. So this was, I think, the last picture. This was the file given to me for your presentation. I have some time. Now I will quickly go show you this slide, only the pictures of this slide. Can you see this one? This is the lecture which I delivered to the BDS students. Anyone knows what is apoptosis? Let's see. Compare the BDS students with the medical students.
Program cell death.
Yes, mashallah, mashallah. Very good. A program cell death, this can occur. There's one question also. I was going through this file. So, but we are concerned with the pictures of necrosis. We have little time left. I want to give you some rest also. So here we are classifying them as different. There are some more which have not been mentioned in your file. One is the gangrenous and one is fibrinoid also. They have not been mentioned. So the same thing from the kidney. When you look at the microscope, you can see on this side, this is normal. You see the bluish dot, all these are nuclei. This is the glomerulus. These are tubules. They have nuclei. These are alive. They are not necrotic. But when you look at this part, all these tubules, they have no nuclei. Or you can see RBCs and inflammatory cells between the tubules, but the tubules, they don't have nuclei, so they are necrotic. But still you can identify that they were tubules. You can still identify this was kidney. That is why we are calling it coagulation. Because during this necrosis, the enzymes, autolytic enzymes are also destroyed. So there's no liquefaction in these infarcts. This is the heart. We have seen there's no extra picture for that. Same thing, normal fibers and inflammation between the, again, you don't see any nuclei in them. This is the brain. You can see when there's infarction in the brain, you get liquefaction because a lot of fat, a lot of cholesterol in the brain. So you see a lot of there are the foamy cells. You see the fat which is dead, now it's taken up by the macrophages, where in the brain they are called microglia, special name to the macrophages. When they eat the fat, they become foamy. So all these are foamy macrophages in the brain. So in the brain, you get liquefactive necrosis because there's a lot of fat in the brain. This is the comparison of coagulative necrosis and liquefactive necrosis in the same organ. So you can see this was the kidney. You can see the glomerulus here. You can see glomerulus. These are all tubules, but all necrotic. There are no nuclei. They're all necrosis. But still you can say it was kidney. But in this kidney, this area got an abscess. So this is an abscess in the kidney. This part, you cannot say what is it really kidney. You can see kidneys here. You can see glomerular tubules, but in this part, there's no structure. This has got liquefied. Around it are the inflammatory cells, but this part is liquefied. So this is a liquefactive necrosis and abscess in the kidney. So this is a comparison of the two. This is the coagulative necrosis. This is the liquefactive necrosis here. Now coming to the gangrene. See, gangrene can be two types. One is the wet gangrene, which occurs in the intestine. You have seen that picture. This is the dry gangrene. Again, when there's necrosis, this occurs in the diabetes usually. When there's blood vessels, they get blocked. So these peripheral tissues, they get dead. Then the bacteria in the atmosphere, they come and attack this dead tissue, and they will be very bad smelling. And they'll eat these dead cells and black in color because of the production of sulfite organ chemicals. So this is the dry gangrene in the feet. Now this is the caseation necrosis of the tuberculosis. You said this is the part which is necrotic, and these are the special features of tuberculosis. And this is how grossly it looks like, cheese-like on gross examination. So this is a caseation necrosis. This is the fat necrosis. This is the omentum. You know the omentum is present in the stomach, in the abdominal cavity. So whenever there's problem in the pancreas, the pancreatic lipase, they are released from the pancreas and into the peritoneal cavity. they form this type of necrosis. You can still see the fat, you can see the round fatty structures, but there are no nuclei. That's all dead tissue. Grossly, again, some calcium also comes. We call it saponification, like soap formation, and this is the fat necrosis in the abdomen. Fibrinoid necrosis, special type of necrosis in the blood vessels due to antigen-antibody reactions. The antigen-antibody reaction, they deposit in the wall of the blood vessels. They give like a fibrin-like appearance. So this is the fibrinoid necrosis. Thank you very much. This is the question. Now, anyone can answer this question. We put these questions to the students during the lectures. Single best question. Which type of cell death occurs because of both physiological and pathological causes? Necrosis always occurs because of the pathological causes. But apoptosis can occur, some of the apoptosis can occur physiologically. You know, embryologically, many parts are formed, but when the child grows, the infant grows, some part they disappear. And this disappearance is because through the help of apoptosis. So apoptosis is a programmed cell death. It is at the wish of the body, and it is programmed in physiological condition and pathological conditions. So apoptosis is the answer. There's another type, the croptoptosis, paroptosis, etc. These are the two important ones, which was based on. Thank you very much. Any questions, please? You can ask me now. Or you can say these are the apoptotic bodies. Or you want to ask me later?
Doctor, can you send us these slides?
You want me to send you the lecture of the dentistry? Okay. Yeah. The whole lecture, only the pictures?
The whole lecture.
Okay, inshallah, I'll send all the lecture, inshallah. I'll send to Yusuf Jamil, inshallah. Any other question? Thank you very much. Ma salam.
Doctor.